Hello, my name is Daphne Cornish. I'm a PhD candidate in the Division of Infectious Diseases, and today I'm going to talk to you about developing new strategies to help us win the war against human immunodeficiency virus, or HIV. So in the past 40 years since the beginning of the HIV epidemic, we have been challenged with a very formidable viral foe in the form of HIV. So to give you a little bit of context for the scope of the challenges presented by this virus, since the beginning of the epidemic, 85 million people have been infected with HIV. And in individuals who are infected with HIV, if it remains untreated, this can lead to the development of acquired immunodeficiency syndrome, or AIDS, which can be fatal. And because of this, over 40 million people have died from HIV-related causes since the start of the epidemic. And part of this is driven by the fact that there is no vaccine against HIV infection, which is in contrast to many of the viruses that we're familiar with in daily life. And furthermore, there is no cure for HIV infection. Once you are infected with HIV, you are infected for life. And so these unique characteristics of the virus lead to a large public health burden and many issues that still remain to be addressed with regard to this virus. And so why is HIV so different from other viruses in this context? Well, part of this stems from the fact that HIV is one of the fastest mutating viruses. I want to give you all an example that I think we can relate to in a comparison to the mutation rate of SARS-CoV-2, the causative agent of COVID-19. So here I have a chart showing the mutations that took place in SARS-CoV-2 over the course of 1 year in Chicago. Basically, each dot gives you a representation of the mutations that occurred. And this is looking across the whole SARS-CoV-2 genome. Now, if I wanted to show you the same chart for HIV, in fact, if I wanted to show you a chart for just a small portion of the HIV genome in comparison to this, it would not even fit on this slide. So instead, I'm going to zoom out and show you this little dot is all the mutations in SARS-CoV-2. This is all the mutations in one tiny portion of the HIV genome, just showing you how rapidly this virus is actually mutating. And as fast as this virus mutates, we have tried to keep up with this by developing new treatments for people living with HIV. Here, I'm just showing you a representation of all of the treatments that are currently in use for people living with HIV. And even though we have so many treatments, it is still not enough. And part of the reason is that mutation rate that I was talking about. So you can imagine a person who is infected with HIV and gets access to treatment for their infection. And perhaps this treatment does a good job in reducing the amount of virus in the body of this person. But what if this person has a lapse in treatment, has to come off their treatment for some reason? In this case, the virus will begin to replicate and mutate. And this could lead to development of mutations that actually lead to resistance to your old treatment, which means you have to find an entirely new treatment to start to reduce the amount of virus in your body once again. And this can be a vicious cycle where a patient living with HIV may experience this many times throughout their life course, meaning they actually go through a wide range of HIV treatments throughout the course of infection. And even if an individual finds an effective treatment for their HIV infection, there are still significant health concerns that are related to both having to take medication for the rest of your life to treat this infection, but also the chronic nature of this infection, the fact that it remains for the entirety of your life. And this includes cognitive deficits, development of liver toxicity and kidney impairment, and also development of heart disease. And all of this leads up to the fact that people living with HIV typically die 10 years earlier than uninfected individuals. So it's clear that there's still much work that is left to be done in developing therapeutics for these individuals. And this is where my work comes in, thinking about how we can develop better treatment options for people living with HIV. And I specifically study the battlefield that exists between HIV and the cells that it infects in order to learn how our body naturally fights against HIV infection to inform the development of new therapeutic strategies. So let's get a sense of the actual battlefield that's taking place in our fight between HIV and human cells. So we can think of HIV as an invader of cells that wants to take control of the cell and produce more copies of the virus. So here in this schematic, HIV contains a copy of its viral genome, and we can think of this as orders that it wants to deliver to the nucleus or the command center of the cell to direct the production of new virus. Now, this diagram makes it seem pretty simple. For a variety of reasons, it's much more complicated, but one of those reasons is the fact that there are many proteins in the cell that actually interact with HIV throughout its journey, and these are known as host factors. And there are a couple of different flavors of host factors that have different impacts on HIV infection depending on the way that they interact with the virus itself. So one class of these host factors are known as restriction factors. And if we're keeping in line with the battle metaphor, these essentially serve as grenades that impede the virus from completing its course of infection, and it can no longer deliver its top secret message to the command center to make more virus. But there are actually also a flavor of host factor known as dependency factors. And these factors essentially serve as traders that actually help the virus to complete its infection cycle. You can think of these kind of as a Trojan horse smuggling in HIV into the cell. And so the reason that I study these host factors is because the way that they interact with the virus itself gives us a clue on how we can actually control viral infection. So many of the host factors that I study actually interact with the viral capsid, which is this conical structure that I've shown here. And depending on the way that they interact with this capsid, they can actually influence the course of infection. Now, interestingly, we have the capsid previously was understudied, and it was unclear whether or not this would actually be a drug target that we would be able to pursue therapeutically. But it turns out, actually, now that we know more about the way that host factors interact with this capsid, it is in fact a druggable target. And in fact, the FDA recently approved a capsid interacting drug that is now in patients and increases the number of options that are available to these patients. So ultimately, through my work, I hope to understand how these host factors are interacting with the virus in such a way that we can learn how to promote the activity of restriction factors, or perhaps even mimic their activity through the use of drugs, and prevent dependency factor activity such that we're able to develop new options for people living with HIV who are in sore need of better treatment. Thank you.